Welcome back, everyone. So next we're going to kick off our next round of abstracts by folks who've been in the meeting. So I'm going to introduce our first session. Give me just a second. So we have Martha Moore Monroy and Berta Carbajal, who will be talking about community campus partnerships, key role in identifying and addressing social determinants of health impacting MCH.
Okay, we're recording.
Hola, everybody.
Ready, Berta?
Okay, so we're happy to be here. Thank you so much for this opportunity to present on community campus partnerships, key role in identifying and addressing social determinants of health impacting maternal and child health.
And here are the co-authors of the presentation. They are part of the Maternal and Child, Title V Maternal and Child Health Assessment Data Collection Team. And so we're going to use ADHS, our ADHS Title V Maternal and Child Qualitative Assessment, as to highlight the importance of community campus partnerships for health in conducting assessments in community. And the Title V assessment is conducted every 5 years. To provide spaces for families and youth for underserved communities to talk about their health needs and their experiences using health services.
And methods: partnering with communities to reach communities whose voices have traditionally not been included. We've partnered with community health worker networks, such as the HOPE Network, helping other promotores excel. Community and health networks and meetings, participating in opportunities where we can bring together community health workers, promotoras, at meetings. Community campus partnerships, networks, school districts, state, county, and community health programs, community health centers, First Things First networks. Many of these networks, which have promotoras or community health workers, but under other titles possibly, but who are utilizing the promotora model.
So ADHS wanted to ensure that everyone had an opportunity, or every type of community had an opportunity to participate. So this graphic demonstrates who and where the priority communities that we attempted to reach were. And here's some of the data collection strategies. So we used a variety of strategies so that we could use strategies to match specific communities. So we used roundtable discussions. We had the River of Life activity, which is very effective at when you have people from different backgrounds, different literacy levels, and different levels of education, or even that speak different languages. We had key informant interviews, we had listening sessions, and we had some participant observation.
And how and why are these partnerships essential? Well, very important. And, if we're all familiar with the promotora model, a very important key and success to the model, the promotora model, community health worker, is to build trust based on long-term collaborations. It's mutually beneficial, based on mutual respect, provide resources to the community with or without funding, respect the community as experts, because they're the experts of their community, respect community boundaries, and acknowledge historical trauma and past mistreatment. Elevate the voices of the community and provide real life experience to students and faculty. Very important. We often remind our community, your voice matters, your voice is important, your opinions are valuable. critical role of community and campus partnerships in the success of the assessment. Vital to the success of any assessment. No one understands the assets and the challenges of the community more than those who live there. Ensures the data and the collection methods and data are community, linguistically, and culturally relevant. Provides a depth of information and understanding. And it actively involves those most impacted in the process to develop solutions.
So we were able to build on our long-standing relationship with the community through these community campus partnerships that, we've been able to develop that trust and social capital. And that was really a foundation for the success of the assessment and of most of our work. And so we were able to identify the assets, challenges, and relevant social determinants of health impacting maternal and child health in Arizona. We were able to ensure representation of every county in Arizona and, the landmass. At the very least, that we had, a county represented at one of these statewide meetings or one of these other networks that we worked through. We ensured the representation of communities whose voices are not traditionally heard or in the past not included, and this was very important to ADHS. And so, as you can see, we were able to reach at least touch every one of these communities in some way. And again, it's thanks to these very strong community campus partnerships that we've developed over many years. And we'd like to thank you for taking the time to attend our presentation. Please feel free to contact us if you have any questions, and our contact information is right there.
Thank you.
Thank you so much. Does anybody have any questions? I was wondering if you might share a little bit more. You mentioned the River of Life activity, and I'm not sure that everybody knows what that entails. Can you speak to that just a little bit?
So the River of Life, we've used it for many, many years. And my favorite story is we had a grant, a REACH grant, where we had subrecipients all over the country. And there was this group from Texas that was working with a faculty member from Texas A&M. And they were from the colonias right by, I think, Brownsville, or in that area. And he didn't speak any Spanish, and most of the promotores didn't speak any English. And so they were able to use this tool. So basically, it can be used a lot of different ways. But what it is you have people draw. And it's really great at bringing folks who are at different educational levels together. So because again, people with higher ed get really sometimes intimidated when you put a crayon in their hands or a marker in their hands, right? And so what you do is you have folks draw a river, right? And at the end, you'll put a goal, where do they want to be? And so in this case, it was, where do they want to be in terms of maternal and child health in Arizona? And then through the river, we always start with an asset-based approach, right? Because it's really easy to find problems. And one of the things we all have to remember is that every community, no matter how many issues they have, they always have at least the very basic resource of people, right? So we'll have them start with the assets, and they'll draw the assets in the river, and then we'll start talking about the challenges, and it creates this really wonderful discussion, and it prevents, or it tries to prevent the professionals from using too much jargon, but it also kind of brings everybody down to as much of an equitable level as possible. And like I said, it was amazing how this group from Texas A&M were able to communicate with speaking very different languages, and it gives folks, also people from different communities, and it's a nice way of having folks sort of negotiate in a non-threatening space about, where they see priorities. So it was that. We've also used it for bike programs, and instead of a river of life, we draw a roadmap. So I'm working with ADOT on a toolkit that they're working on, and we're adapting part of that too. So
That's really cool. I think that's useful for everyone's work. I think we need to transition to the next one, but thank you. And if anybody has any kind of follow-up questions, please feel free to add them to the chat, and the authors of that session can address them as we move into the next one. Let's see, which is we're going to talk about Parentese, turn taking and language development effects of parent coaching. That's by Naja. Is it Naja or Naja Ramirez?
It's Naja.
Oh, Naja. Sorry about that.
Hi, my name is Naja Ferjan Ramirez, and I'm here to talk to you about a recent parent coaching intervention. Decades of research have demonstrated that parental language input plays a very important role in language learning. We typically think of input in terms of both quantity and quality of language that infants hear. In terms of quantity, we typically talk about the number of words that young children hear, and strong positive associations have been shown between quantity of caregiver input and infants' vocabulary growth. When it comes to quality, of course, there are a number of different measures of input quality that have been shown to be important, such as parental responsiveness, using more affirmatives or encouragements, less prohibitions, producing more diverse input, and so on. Today, I want to focus on one aspect of parental language quality, and this is Parentese. Let me show you a very short audio clip just so that we are all on the same page about what Parentese is.
Find your shoes so when we go outside, you have shoes. 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 No shoes there. There they are. There are your shoes.
So Parentese refers to the speech register that adults adopt when addressing young infants. And here on the slide, I'm showing you an example of expanded acoustic space in mothers in Russia, Sweden, and in the United States who used Parentese. Parentese also has a higher pitch, slower tempo, exaggerated intonation, and regularized rhythm. The utterances are shorter. The grammar is simplified. There's lots of repetition, more pauses, and a high proportion of isolated words. Then, of course, we also tend to smile a lot when we produce Parentese. We have widened eyes and high affect. Now, studies in labs have shown that exposure to Parentese as opposed to standard speech facilitates language learning and processing. I'm just listing a few of these studies here. This is not an exhaustive list, but these findings suggest that Parentese facilitates the process of language acquisition as well as language processing. In the present study, we asked whether parents can be coached to increase Parentese in their daily interactions with infants, and if they can do that, does this have an impact on child language outcomes? The approach that we took was that we considered 71 English-speaking families, and we started this intervention when the babies were 6 months of age. We split the families into the intervention and the control group and matched them on all important characteristics. We recorded all families, intervention and control, with the Lina technology, but we only coached the intervention families at 6, 10, and 14 months. What is Lina? The language environment analysis, or Lina technology, facilitates day-long recordings in children's natural environments. We have a little recorder called the DLP that we can simply snap into a pocket of a child's vest. And this DLP records up to 16 hours of sound. We can then use statistical modeling and the Lina algorithms to obtain some automatic estimates of the number of words, number of back and forth interactions that the child is engaged in, as well as the number of child's language related vocalizations that the child produces. We can then also perform manual analysis to determine some additional characteristics of parental input, such as the proportion of parentees that they use, as well as things like the number of infant words in the recordings. In terms of what we did during parent coaching, these were 45-minute individual coaching sessions that followed a 4-step format. We provided linguistic feedback to the parents based on the Lena recording. So we told them how much parentese they used. We had parents listen to audio samples from their own latest recording. We suggested concrete interactive activities to do with their baby, and we discussed upcoming language milestones. So now let's look at the results. We will look at both parental language input and infant language outcomes. This first slide shows the significant effect of the intervention on enhancing parental use of parentese. So intervention parents who were coached increased their use of parentese more than control parents between 6 and 18 months of age. Now let's turn to turn taking or conversational turns, the back and forth exchanges between parents and infants. What we see is that the intervention significantly enhanced turn taking between parents and infants. So parents who were coached enhanced the number of back and forth interactions that they had with their infants. Now, if we turn to infants, we see that infants whose parents were coached produced a higher number of language-related vocalizations as determined automatically by Lena, and they showed a greater increase in their production of language-related vocalizations over time. Finally, if we look at infants' language outcomes at 18 months, these are measured manually within the Lena recordings. We're looking at the number of words that infants produced. We see that the intervention kids outperform the control kids. And also the same finding applies when we look at parental report. So based on these findings, we conclude that parents across a pretty broad SES spectrum here can be coached to enhance specific components of language input, in this case, parentese and turn taking, and this can immediately and positively affect infant language outcomes. Now, some potential follow-up studies, some of these we have already conducted. The first question is, are parentese and turn taking related to infant brain structure? We have actually data on this, and the answer seems to be yes. Of course, are early parentese and turn taking in infancy, are they related to kindergarten readiness? We are going to be able to have this answer pretty soon because these infants are now gonna be kindergartners pretty soon. And then finally, we have follow-up studies where we're looking specifically at the differences between moms and dads as they produce parentese in much more diverse samples, including multilingual and bilingual samples. We are looking at parentese and turn taking in the NICU, as well as looking at some studies with infants who have hearing impairment. Thank you for listening.
Thank you, Naja. We have a couple minutes for Q&A. If anybody has a question.
Naja, this is Nancy Shear, and thank you for your presentation.
Thank you.
Can you, you did the intervention just when they were infants and you're following them. So there's a lot that could go on, obviously, between when you did the intervention and later on. So how are you following the children in terms of what other programs and interventions that might go on in for the parents as well as the kids?
Yeah, thank you for this question. So one thing to know is that when we initially designed this study, we were only planning on following these kids up to 2 years, but then it went so well. Everybody was so excited. All the parents were super excited about this. So we were able to then secure some additional funding, and that's why now we are able to re-recruit them into other studies. And of course, we're super interested in this, right? But the study wasn't initially designed for it. So whatever measures we can get at a later time point, we're just grateful for those parents who want to re-engage with us, which, to be honest, is the bulk of them. So we're looking at their kindergarten readiness. Of course, everything has to be done online. We took brain measures with these kids at 26 months. We followed up on vocabulary up to 30 months, and all of that is highly significant, continues to be. And then we kind of had a gap between 30 months and what are they now, 4.5 to 5 years. So at 4.5 to 5 years, we're probably going to do additional, so follow-up Lena recordings, and then I think some testing of kindergarten readiness through Zoom. That's the current plan, and then additional brain scans too, as soon as that's possible.
And are you going to be measuring other programs that they are?
Yeah, we have a whole bunch of questionnaires. You know, this is also the time after 2 years is also the time that any kind of additional like autism diagnosis and all of that, we're screening parents over the phone as much as we can. So we are re-enrolling them and collecting as much information as we can about what happened during this gap. But you're absolutely right. A lot of stuff can happen. So if we don't see the effect of coaching, that could be to a number of different reasons. Or if we do, right, we'll see.
There's some more questions. Let's see, the most recent one is about cross-cultural and bilingual differences.
Sorry, can you repeat that?
Oh, sorry. Yeah, let me just read it. It's just hard to look at different screens.
Okay.
Are there differences reported among bilingual or multilingual or multi-language versus single language?
So this study was all just English-speaking families because it was our start, but I'm actually right now I'm preparing a similar, well, not actually exactly similar, but I would love to expand this to dual language learners. And I'm working with some partners in Miami actually to see if we can make this happen with families who speak Spanish and English simultaneously. And of course, a big goal of mine is to also expand this to families of lower SES. So here we went for a widespread SES, and we do have families of a range of SES, but of course we know that the families who would benefit from this the most are likely the lowest SES families. So in our future work, that is absolutely the plan to kind of target those populations.
Very exciting work. I actually have a ton more questions, but I think that we need to move on. So thank you, Naja. And maybe you could come and present to our maternal child health.
Absolutely. Anytime.
Great, thank you. All right, let's see who is next. All right, so the next presentation is going to be the nature of intensification within school-based speech-language pathology. So that'll be with Lurel Bruce from College of Health Solutions, and Jean Brown, also from College of Health Solutions. So thank you, Lee.
Hi, my name is Lurel Bruce.
And I'm Jean Brown.
And our presentation is the nature of intensification within school speech-language pathology. SLPs, or speech-language pathologists, play a role in child health by providing services in a variety of different settings, including schools, hospitals and clinics, and in-home early intervention. Additionally, 96% of speech-language pathologists are women, and many have their own children at home as well. As a result, SLPs are situated at the intersection of maternal and child health vocationally and often personally. Today, we'll be presenting data from a survey of 335 United States-based speech-language pathologists. So this project was developed as the result of learning about a concept within the educational literature known as intensification. And in the 80s, Michael Apple developed his intensification thesis, which essentially was used to describe the increasing demands on teachers' workloads in light of changing societal and economic pressures. And the impact of this was kind of an emotionally taxing sense of overload for teachers working in the schools, both during the school hours as well as beyond. And we did a qualitative interview study in 2019 with 14 speech-language pathologists in the Metro Phoenix area. And so the results of the study indicated that speech-language pathologists working in education also experience characteristics of intensification. But this was all done pre-COVID. So along comes COVID and a situation, and the intensification experienced by speech-language pathologists was only heightened. And so we decided to do a survey to see what the impact of COVID-19 was on school-based speech-language pathologists specifically. And now I'll turn it over to Jean.
Have you ever heard the term out of the pot, rather, into the fire? I think that's what happened with COVID-19. Another one of the phrases that I'm really familiar with is out of one of my favorite children's show. It is the Rudolph the Red-Nosed Reindeer. And there's a storm coming, and all of a sudden the snowman said, "It hit." So it truly hit. Once upon a time, we were working with our students and our clients face-to-face, working on speech sounds, and then we had to go from what we're calling remote learning to emergency learning. And so everything was intensified. We already had intensification with workload, paperwork. That's the nemesis of being a speech-language pathologist. It's just the paperwork. Sometimes you don't get to the students. So here we are now in spring of 2020 when most of us in March had to use another format. Most of us were using telepractice or home packets, or, and as incredible as it may seem, services were put on hold. So what does this intensification look like? What did it look like? And what does it still look like for some of us? Well, most of us had to do telepractice training, and I was among them and didn't have a clue. If you had asked me before COVID, I would have said that telepractice wasn't essential, but it became a very essential service. And we didn't receive a lot of immediate support from our organization, ASHA, but we had to go online. We had to find ways to meet the needs of our clients. And a lot of us helped each other out as well. Some of us had previous training. Some of us were working with contract companies. They helped us out. And some received help from the state level. But most of us scrambled and we got telepractice hours where we could get them. And I can say that for myself, that was very, very helpful. But getting those hours meant that we were working more. We were already working more, and that was just intensified. Working more hours, trying to learn telepractice, trying to figure out new service models to meet the needs of our clients. And if you know anything about speech-language pathologists, one of the things that's most important to them, especially in the schools, is meeting the demands of not only their personal demands or of ethics, but of their school districts and the state, and of course, on some level, the federal mandates to give these kids what they need. So, more intensification. The families that I work with were technologically prepared to begin telepractice. Like us, they were not ready. The parents weren't ready. They had to struggle with the needs of their kids, the needs of their families, and some of them were working and teaching their kids at the same time. So I can see where no one was prepared for the great storm of 2020. So what areas of difficulty did they experience? Work-life balance. A lot of comments about this, trying to balance that and be a juggler, to be a good mom, to be a good wife, to be a good worker. Learning new technology, as was mentioned before, procuring needed materials, to work at home. If you were in your office, you could just go pull something off of the shelf. I even found myself just going through the house trying to find materials. And then if you were trying to meet kids in person, did you have the PPE that you needed? And then, of course, those wonderful hours that we were all missing in therapy time. IEP goals were not met. And then administrative expectations. One of the things I think is going to be a challenge is that we were all used to working with our clients in person. We were now, it was incumbent upon us to learn ways to do speech sounds through telepractice. Sometimes that technology failed us, the Wi-Fi wasn't up, or the students just didn't even have what they needed to do that. And I guess one of the great fears going back in person will be, will I have what I need? Will I have the PPE? Will I have the technology or the support that I need? And that's a great looming fear. And I think that leads to a lot of anxiety about just what's going to happen in the future. I think we have a great opportunity with this study to delve even deeper into the possibilities of how we can support each other and make it a better experience, not only for our clients, but for speech language pathologists. As one who I can say we have a lot to offer these kids, because communication is vitally important. And during COVID, sometimes that was put on the back shelf because of more immediate needs like safety, health, and safety. But we'll be going back on the ground. We're all excited about doing that. And we're all excited about looking for a solution. Maybe it won't be Rudolph's nose, but it'll be something novel that will help us all. Thank you for your attention to us today. And if you have any questions or comment, Laura and I are both here to answer those. Thank you.
Great, thank you so much. Does anybody have any questions? I was wondering if you guys had thought about like how, what can be done to reduce burnout. I think this is, obviously not just a problem with SLPs, but kind of across the helping profession. So have you thought about, what could be done there?
Yeah, I think that there are, I've seen a lot of discussion in the last year or so about how to reduce that. And I think that one of the things that I have seen is SLPs using each other and connecting via social media. Speech pathologists, particularly in the schools, often can work in isolation from each other. And so I've seen a lot of speech language pathologists using social media to connect with one another, to gain resources, to try and pool resources and ideas together in order to kind of streamline some of the effort. Yeah.
I see some people resonating in the chat.
Yeah.
All right, just for the sake of time, I'm gonna move us to the next presentation, but please, if you have additional follow-up questions, put them into the chat. So now we're gonna hear about the child fatality review, deaths among children in Arizona. What is it and what do we do? So this is from Jessica Perfette from the Arizona Department of Health Services Bureau of Women's and Children's Health.
Hello and welcome to Child Fatality Review, Deaths Among Children in Arizona, What It Is and What We Do. I am Jessica Perfette, the Child Fatality Review Program Manager with the Arizona Department of Health Services. The Arizona Child Fatality Review Program's goal is to reduce child deaths in Arizona by conducting a comprehensive review of all child deaths to determine what steps could have been taken, if any, to prevent a child's death. We're going to look at the 2019 child death highlights. In 2019, 777 children died in Arizona, a decrease from the 843 in 2018. The Arizona child mortality rate has steadily decreased from 2010 to 2019. The CFR teams determined that 44%, 341 total, of the 219 deaths could have been prevented. A child's death is considered preventable if the community or an individual could have reasonably had done something that would have changed the circumstances that led to the child's death. We have 5 different manners of death that we classify: natural, accidents, homicides, suicides, and undetermined. The top 5 leading causes of death were prematurity, congenital anomalies, motor vehicle crash, suffocation, and cancer. Substance use was involved in 119 of all child fatalities, and firearms were not stored in 56% of the firearm-related deaths. Now we're going to look at the demographics for all children. The number and percentage of deaths, the majority of child deaths were due to natural causes at 60%. The majority of male and female child deaths occurred among those birthed to 27 days of age. American Indian, Alaskan Native, and Black African American children made up 9 and 12% of child deaths, but only comprised 5 and 6% of the total population. The main purpose of the CFR program is to identify preventable factors in a child's death. Each multidisciplinary team is comprised of professionals who review the circumstances surrounding a child's death by reviewing records ranging from autopsies to law enforcement records, and the team determines if there are any preventable factors present prior to the death. They use one of the following 3 labels to determine preventability: yes, probably, no, probably not, or could not determine. As you can see, 44% of the child deaths were probably preventable, followed by 51% probably not, and 5% undetermined. Among preventable deaths, motor vehicle crash was the #1 cause of death for all children. CFR teams determined that 7% of natural deaths, 100% of accidental injury, suicides, and homicides, and 92% of undetermined deaths were preventable. Infants between the ages of birth to 27 days and children ages 5 to 9 years had the lowest number of preventable deaths, while the children 15 to 17 years of age had the highest number of preventable deaths. American Indian, Alaskan Native, and Black African American children made up 13% each of preventable child deaths, but only comprised 5 and 6% of the total population. Now we're going to look at the different manners of deaths. For accidental injury deaths, we had 178 in 2019, which was a 5% increase from 2018. The top 3 causes were motor vehicle crash, suffocation, and poisoning. Of those, 63% male, 37% female, and 32% of them occurred in our 15 to 17 year age range. 30% of them involved substance use. We had 59 homicides in 2019, which was an 89% increase from 2018. The #1 cause was blunt force trauma, followed by firearm injury and other. Of these, 68% were male, 32% female, with 29% of them occurring in our ages of 15 to 17 years. 41% of them involved substance use. In Arizona and nationally, deaths classified as natural deaths due to a medical condition account for the largest percentage of child deaths each year. We had 465 of them in 2019, which was a 14% decrease from 2018. The top 3 causes were prematurity, congenital anomalies, and cancer. Of those, 57% were male and 43% female. We saw a little over half, 55% of natural deaths occurred in our neonates that are less than 28 days of age. 3% of these involved substance use. We had 38 suicides in 2019, which was a 41% decrease from 2018. The top 3 causes were strangulation, firearm, and poisoning. Of those, 58% were male and 42% were female. 58% of them occurred in our 15 to 17 year of age range, and 29% of them involved a substance use. There were 37 undetermined deaths in 2019. 92% of them were preventable, and of those, 65% were male and 35% were female. 73% of them occurred in our infants, and 38% of them involved substances. Now we're going to look at the main causes and contributing factors of death. Abuse and neglect is an act or failure to act on the part of the parent or caregiver of a child, resulting in a serious physical or emotional harm of the child. We had 100 abuse necks in 2019, 33% increase from 2018 to 2019, with the top 3 causes as blunt force trauma, suffocation, and undetermined. We had 57% male and 43% female. 58% of them occurred in our infants, and 49% of them involved substance use. We had 19 drowning deaths in 2019, which was a 29% decrease from 2018. 63% of them were male and 37% were female. 47% of all drowning deaths occurred in the 1 to 4 year olds, followed by our less than 1 year of age and 5 to 17 years of age at 53%. Substance use was involved in less than 6. There were 36 firearm injury deaths in 2019, which was a 15% decrease from 2018. 72% were male and 28% were female. Little over half, 58% of them occurred in our 15 to 17 years of age, and 53% of them involved substance use. We saw 61 motor vehicle crash deaths in 2019, which was an 18% decrease from 2018. 59% were male and 41% were female. 44% of them occurred in the 15 to 17 year age range, and 25% of them involved substance use. A death due to prematurity is when an infant is born before 37 weeks gestation and the cause of death is related to that premature birth. We had 170 prematurity deaths in 2019, a 1% increase from 2018. Of those, 60% were male and 40% female, and 5% involved substance use. Out of substance use related deaths, that's where the child or any individual involved in the death of the child used or abused substances such as alcohol, illegal drugs, and or prescription drugs, and this substance was a direct or contributing factor in the child's death. There were 119 substance use related deaths in 2019, with the top 3 causes of poisoning, firearm injury, and motor vehicle crash. 71% were male and 29% were female, and half of them occurred in our 15 to 17 years of age range. For SUIDs, or sudden unexpected infant deaths, there were 75, which was a 26% increase from 2018. Suffocation was the #1 cause. Sleep-related injury deaths are identified by reviewing all potential cases of children less than a year of age. A death is considered sleep-related if the child was found in a sleep environment or if the last time they were seen alive is while they were asleep. In addition, it could be a natural cause of death if the death was sudden and unexpected and the infant was in a sleep environment. 63% were male, 37% female. 92% of them occurred in infants aged 28 days but less than a year, and 25% involved substance use. We do have prevention recommendations in our annual report I recommend you to check out. These are the examples for prematurity recommendations, which was our highest cause of death. For more information, please check out our 27th annual report at the link below. Thank you. And do you have any questions?
Wow, thank you so much. That was a heavy presentation. Does anybody have any questions?
I have a question. How I noticed that about 5% of the prematurity births were preventable. How was that determined?
Yes, thank you for that question. So that is based, usually the preventable prematurity ones are involving a substance use. As you can see, there were a couple of those related to those deaths. So those are usually the ones that we capture as preventable.
I just wondered if it was a lack of medical attention that caused that.
Not necessarily. Usually it's a factor. Trying to think. Yeah, that's usually not what we see. I would say the bulk of those, if not all of them, are usually due to a substance.
Okay, thank you.
Yep, thank you.
I was kind of curious about, so for each one, you pointed out like demographic differences, which is really heartbreaking to see all those continued issues, but also the substance use, like how many of each of those was related to substance use. I'm just wondering how that got added in as something that you looked at.
How we added in the substance use?
Yeah, from a historical perspective, how did that become something that that was decided to be important to look at for each type of death?
I know recently with the CFR program, we've really looked into that just with the increase of opioids we've been seeing here, but that's something we've always kind of tracked over at least the last 10 years, but we really dived into it the last, I would say, like 5 years of just looking at how many substances, either as a child or the adult as the user or both, that contributed to these deaths. That way we can really step in and focus our prevention efforts appropriately.
This is Dolores. You did an excellent job. The content just really good. Your summary really well. But I don't know if I missed it, but did you mention anything related to number of prenatal visits in terms of the outcomes, and then also in regards by ethnicity?
Yeah, so I tried to wrap up it's over 100-page report in only 7 minutes. So I really recommend you
Right,
check out
yeah,
our
and
annual
you
report
did a great job. You did a
on
great
our
job.
website. We do track the number of prenatal visits and the timing that they entered prenatal care with the gestational age in terms of prematurity. So that is in our annual report. And then there was on the slide, I just didn't have enough time to read it, of the disparities between the race and ethnicity for the different manners and then also the main contributing factors. But it goes into a lot more detail in our annual report if you want to look at the disparities of the different race ethnicities compared to their population. That's in there.
Thank you.
Of course.
Great, thank you so much. Could you put the link for that report in the chat, please?
Sure, I can.
Great. And then we will move on to our next presentation. Again, thanks so much. And, you know, folks continue to put in comments and questions in the chat. So next we will have ecological approaches to childhood or child obesity from Liz Reifsnider from the ASU Edson College of Nursing and Health Innovation.
Hello, I'm Elizabeth Reifsnider from the Edson College of Nursing and Health Innovation, and I would like to talk to you about child obesity and human ecology. What's the connections? This is a study we did comparing the different levels of child ecology, human ecology, to obesity. The purpose of this study was to understand an ecological perspective on the development of obesity in children. We looked at the microsystem, mesosystem, and the epidemiologic triangle, which is agent, host, environment. This study took place in Hidalgo County, Texas, which is close to, it's on the Mexican border and it's close to the Gulf of Mexico. And it's what's in the area called the border, which is almost a unique culture combining Texas and Mexico. It was a cross-sectional descriptive study. The total sample was 55 mother-child dyads, so the total sample was 110 people. We recruited the children from the Special Supplemental Nutrition Program for Women, Infants, and Children, which is known as the WIC program, at Hidalgo County Health Department in Hidalgo County, Texas, on the border. The children were ages 1 to 3. This is the ecological framework we used. So if you think of all of South Texas as a mesosystem, which like I said is sort of its own unique culture, the exosystem was Hidalgo County in particular. The mesosystem is what surrounds the family environment. So this is maternal employment, daycare, maternal acculturation, or basically the culture that's in that area. The agent, which was food, the agent comes from the epidemiologic triangle, includes the beverages the children drank, their vitamin intake, when did they get food, how long were they breastfed, how long were they bottle fed, and did they stay on the bottle more than 12 months. The microsystem, which is the home environment, that looked at the home screening questionnaire about what went on in the home, the mother's stress, is the mother a single parent, how many people are in the home, how many children are in the home, what order are they, do they eat meals at a table with parents, are the meals organized? And then the host, the child host, was the anthropometrics, how frequently they played outside, and then the mother's basic demographics. And all of these contribute to child obesity. I told you what our sample size was. We had 29 normal weight children, 26 overweight children, all of them whom were Mexican descent. The mothers were 28 to 29. Their education level mean was 10th grade, and most of the mothers like to speak Spanish. Our results, children of normal weight played outside for 4 hours or more, a lot more often than obese children. Mothers of normal weight children weighed less than mothers of normal weight children weighed less than mothers of obese children. Mothers of normal weight children preferred to speak Spanish, about 50% more than mothers of obese children. So when we looked at the food, obese children drank 4 times the amount of fruit juice. And this is like high C or other kinds of juice, fruit drinks that only have 10% of juice or less. Normal weight children took vitamins more often, about twice as often, and obese children were twice as likely to be on the bottle more than 12 months. So when we put all of these into a logistic regression, the first level we put in was just the host. What things about the child and the mother, mattered in the development of obesity? And we were able to explain 36% of the variance in child obesity with that level. Then we added the microsystem, what's going on in the home, the stress, the single parenthood, number of people in their home. And that raised we could explain 51% of the variance that way. Then when we put in the mesosystem, the mother's employment, her acculturation level, it raised the variance to 62%. So we can say that about 62% of child obesity can be understood through the lens of the child's birth weight, what the child eats, how often the child plays, how long it's breastfed, how long it's on the bottle. Then the mother's contribution. Is the mother obese? Does the mother have a more Mexican culture? And then we can look at the family environment, how much stress is in the home. Do the parents, are they engaged with the child? Does the child eat meals with the parents? And then when we add the mesosystem, if the mother's employed, what kind of daycare is available to the children? What's the general culture around the family? Does it support parenting, and does it support healthy nutrition? So all of these things together. So when we're looking at child obesity, we can't just think of only what a child eats. It's so much more than that. So when you work with children that are obese, or you want to start off at birth and help families have healthy children that do not become obese, you need to think of all of these factors because a child's environment is multifactorial, and we need to focus on the social determinants of health. Do they have safe housing? Is there access to play, outside play for the children? Is it a food desert, or are there healthy eating places close by? Can they afford fresh fruits and vegetables? If they can't, do they have nutrition assistance? All of these things you need to think of when you're helping families have healthy children. Thank you for the discussion.
Thanks so much, Liz. That was great. I think we are a little bit over time, but we can have time for one question.
Maybe people are eager to get to lunch.
It could be. Oh, so Katrina asked in the chat, why does the federal government through WIC provide so much fruit juice to small toddlers? Agreed.
Well, there should only, a child at that age really only needs about 4 ounces. I mean, and I'm talking 1 to 3, only needs about 4 ounces of 100% fruit juice. And I've noticed that parents like to give them more fruit juice, especially apple juice. And that doesn't help a child when they're drinking apple juice all day. It produces too many BMs. But I don't know if, WIC really just wants 4 ounces a day, which is, and then once the children start eating, they can eat fruit instead of drinking juice. But I think it is the idea that parents have that, oh, fruit drink and fruit juice is healthy. So the more the child has, the better. And I'm sorry, but apple juice to me is basically sugar water with a little bit of flavor in it. And so I don't promote many fruit drinks except orange juice. Well, really, some type of citrus juice. So that's really what I think, and limit it. Don't let the kids drink juice all day.
Yeah, I think it's not just that the parents think it's healthy, because from my own personal experience right now, my daughter was drinking my father's juice and realized like, wow, this is amazing, and is wanting it all the time now. So it's partially driven by the fact that like kids realize, wow, this is really good stuff.
Yeah, and there's a good comment about juice is expensive. Children should be eating the fresh fruits and vegetables because they're getting the fiber, and they are learning to eat an adult plate.
Great. Well, thanks for all of that. That was really great. And now we're going to move on to our final abstract, which is Parent Resilience is Associated with Positive Diet Traits Among Hispanic Adolescents by Sonia Vega-Lopez from ASU College of Health Solutions.
Hello, and thank you for giving me the opportunity to present today on behalf of the families preparing the New Generation Plus team. This work was supported by the National Institute on Minority Health and Health Disparities, and the authors have no conflicts of interest to disclose. Relative to their non-Hispanic counterparts, Hispanic youth are at increased risk for chronic disease due to multiple factors, including a greater prevalence of overweight and obesity, and greater substance use. At the same time, Hispanic youth have lower compliance with physical activity and dietary recommendations. The role of parents is particularly important due to their ability to create a home environment that promotes healthful behaviors, and the parents' role as providers of resources to the family, including food. However, a parent's ability to perform that role depends in great part on multiple factors that contribute to their physical, mental, and social well-being, including resilience. Evidence linking psychological resilience and diet quality is scarce, but has suggested that higher resilience is associated with lower rates of obesity and with diet traits characteristic of a better diet quality, such as the consumption of more fruits and vegetables and lower intake of soft drinks in different groups of individuals. It has also been suggested that offspring of parents who have less resilience are more prone to obesity and to have less beneficial diet-related behaviors, such as watching TV during meals. In light of the limited evidence available, our study was carried out to determine whether resilience of Hispanic parents is associated with dietary characteristics of their adolescent children. Study participants were 327 Hispanic parent-adolescent dyads enrolled in a parenting intervention randomized controlled trial. All participants were recruited from Title I middle schools with a Hispanic student population greater than 60% from the Phoenix metropolitan area. All adolescents were in 6th, 7th, or 8th grade at the time of study recruitment. Mean age was 40.2 years for parents and 12.4 years for adolescents. Most parent participants were female, whereas there were slightly more boys than girls enrolled in the study. Data used for the current analysis were collected at study baseline via self-administered electronic surveys. Parents reported resilience using the Connor-Davidson Resilience Scale, as well as perceptions about other parenting traits. Adolescent diet was assessed using the National Cancer Institute Diet Screener Questionnaire, from which we calculated their predicted intake of fiber, calcium, whole grains, dairy, fruit, vegetables, and added sugars, both total and from sugar-sweetened beverages, using publicly available algorithms. The 10-item Connor-Davidson resilience scale is shown on the screen. I am not going to go over each item in detail, but as you can see, it asks questions about a person's ability to cope with difficult situations. We use Pearson correlations to assess the associations between parent resilience and adolescent predicted dietary outcomes, adjusting for other parenting variables in partial correlations. As noted by the values highlighted in red in this table, adolescents with more resilient parents had a higher daily intake of dairy and calcium and of vegetables compared to adolescent children of less resilient parents. The positive association between parental resilience and predicted intake of whole grains was no longer significant after adjusting for other parenting factors. Parental resilience was not associated with predicted intake of fiber, added sugars, total, or added sugars from sugar-sweetened beverages. This study has some limitations worth highlighting. First, this was a cross-sectional study, therefore limiting our ability to establish causal associations. There is a possibility of error associated with having self-reported data and with having estimated diet outcomes instead of having objective measures of diet. Our sample size is relatively small. And finally, our study was limited to Hispanic participants, limiting our ability to generalize to the overall population. In conclusion, these findings confirm previous reports and contribute additional knowledge about possible associations between parent resilience and their adolescents' intake of specific food groups, particularly helpful foods such as dairy and vegetables. The specific role of resilience on diet-related parenting practices in Hispanic households, particularly under food insecurity and other financial stressors, warrants further investigation. I thank you for your attention and will be happy to take questions.
Great, thank you so much. Does anybody have any questions they'd like to share? I'm curious if you looked at acculturation, Sonia, just to see, because we know that there are differences between parents who are more or less connected to their like traditional Mexican cultural values in terms of a whole variety of health outcomes. Was that part of the study?
Well, first, thanks everybody for staying this late in the conference. Usually in-person conferences, you have just a handful of people at the end, so thank you. And thanks for your question. We do have data on acculturation, but we did not account for that in this analysis at this point. However, the sample that we have is pretty homogeneous. So I do not think that it would make a huge difference at this point, given that most parents are very oriented to Mexican.
Not, I think we are at time for us to move on to the poster sessions. So I believe that Liz is going to post in the chat how to get over to the poster sessions. Is that right, Liz?
I'm dropping that in, and also a reminder for evaluations and interest form to join the translational team if you want to mention that again, so that I drop that.
So the rest of the conference is a poster session where you can kind of go and visit different rooms and kind of take however much time that you need. And I see a comment, a direct question as to whether we will get copies of the PowerPoint presentations, and we will definitely be sharing. Oh, looks like we already have a link. Oh, I think this link is for the poster sessions, but yes, we will be sharing that information. We're going to compile it all into a Google Drive and then send it out. And then, of course, if you don't have access to that because of your work restrictions, then please let us know when we can help facilitate. But definitely go on over and check out those posters, and thank you so much for attending, and really enjoy the rest of your afternoon and have a great weekend. Thank you.